Okay, everyone. Thanks for joining us in person, and for those who are joining us via Zoom, welcome. I think we have a special treat today to hear from a colleague that I've been, and I'll introduce him in a moment. But just to remind everyone, we certainly want people to get grant rounds CME credit. So the CME number I will put up on the board as well for those who don't see it. 477. Two. Another step. Okay. So get your grand rounds, and we obviously are trying to monitor this. Just a reminder that this is our upcoming program. We have a visitor, Dermot Phelan, next week. I'm sorry that I will not be here in person, but I will definitely be listening in. Subsequent to that, just before Thanksgiving, we have a faculty meeting. And then we have Dr. Gropler, Bob, is coming to do a part of our entire cardiovascular imaging symposium that Dr. Sanusis and others are leading, and will be delivering the Barry Zaret lectureship on December 3rd in his honor. Followed by Rajesh Vidanasan, who's done great work in global health. And then we have some holiday breaks ahead of us. So pretty packed end of year agenda. Also want to remind everyone, particularly those who are clinically very active, to try to do your very best to stop by and socialize and network with our cardiologists across the Heart and Vascular Center, as well as our cardiac surgeons and vascular surgeons. This upcoming Wednesday at the Heart and Vascular Center annual networking, social, and review, which I think is at 6:30 in Trumbull. And so I sent that reminder out earlier this week. Please do your best to join us. These are our disclosures and accreditation. So I have a real pleasure to introduce our guest today, Joao Cavalcante, who he may not realize, but I've been watching him for a long time and really been excited to see the progress he's made for himself and for the field in general over these years. Really wonderful. Just to briefly introduce you, Joao did his medical school in the state of Ceará, in Fortaleza, Brazil, and then came to do his internship residency and chief residency, as well as cardiovascular general fellowship at the Henry Ford Hospital in Detroit, Michigan, which is and was certainly in those days a powerhouse cardiology clinical place, and had a strong clinical trials investigative profile as well. And then went on to do advanced imaging training at Cleveland Clinic before being recruited to the University of Pittsburgh, where he was an assistant professor and rose through the ranks to associate professor through over the last 10 years before being recruited away to lead efforts as part of the Minneapolis Heart Institute program, particularly to lead the section of cardiovascular imaging there, where he's responsible for all cardiovascular imaging modalities, echocardiography, cardiac CT, cardiac MRI. And he's had a really dynamic career, making substantial contributions to cardiovascular imaging guidelines, actually with his membership and leadership roles, not only in the American Society of Echocardiography, but the Society of Cardiac CT and the Society of Cardiac MRI, with a real, very clear focus on the role imaging plays in staging and evaluating valvular heart disease, and in planning and executing procedurally in valvular heart disease. And so he has tremendous experience, really, I think, runs a incredibly high volume program as part of the Minneapolis Heart Institute. So we're excited to hear from him today, and please welcome here to Yale for us. So let me get you started there.
Thank you so much, Eric, for such a warm introduction. It's a delight to be here tonight with you. Coming from Minneapolis, it's privilege to present on behalf of our group, some insights on both aortic and tricuspid regurgitation. Decided to pick one valve on each side so that we can be in peace. And some of the disclosures here that we do core lab work for several device companies and some consulting fees of some of the work that I'm going to be presenting to you here today, but much more to stimulate some of the discussions of how we can do a better job identifying these patients. So before we get there, and I was already a little bit late, but I would like to just get your hands here. If we're going to understand the prevalence of aortic regurgitation. If we define significant valve disease as moderate and severe, please raise your hands. Who do you think if aortic stenosis, significant aortic stenosis is equally common of aortic regurgitation as aortic regurgitation? Aortic stenosis is more common in the community than aortic regurgitation. Or aortic regurgitation is more common than aortic stenosis. You're out of your mind. There's no way. There are three options, right? So let's take a look. Let's look at the data. This is now scanning patients in the community. This is Oxford, Oxvalve, 65 years or older, 2,500 patients. Significant, moderate to severe, 6.4%. Top three are TR, MR, and AR. Aortic stenosis is down below here. This is the Venn diagram, and you can see some aortic regurgitation. So less common than aortic regurgitation by almost twofolds. It's not common, that's not possible. Let's come to Minnesota. Heart of New Ulm is a new epidemiological project that we did in Marigoso. Now, a decade later, 65, now we're going to 75. Predominantly Caucasians, that's the limitation of doing studies in Minnesota. Almost 1,000 patients free of valvular heart disease, 16%, from 6 to 16%. Top three are, as you can see, TR, MR, AR. AS is a third of it. So, I mean, where are these patients? Because we don't see them. It might be in the community. So are we having a problem with the diagnosis? So cannot be right. Let's go to China. We know there is a lot more bicuspids there from the aortic stenosis. And the top three here, actually, number one is aortic regurgitation. The number two is going to be TR, and number three is going to be MR. So with three epidemiological senses here, we have a sense that probably aortic regurgitation might not be as less common, maybe equally common. We just have to wrap up into our diagnosis and understand. And then to understand that there are problems in the diagnosis and have the right treatment if we don't have the right diagnosis. So to frame that, I would like to present this case of a patient that I took care of it. 79, retired psychologist, dance instructor, was presenting now with exertional dyspnea when teaching her classes. She had had a heart failure hospitalization 3 months prior and now presented to us with a high BNP with mild hypertension. And the echo that was done, I'm going to show the images here. And we're talking about that with the fellows. Always look at the source images. Don't just take the report. Showing moderate aortic regurgitation with normal LV size, but no mechanism or no quantification. She had a history of a Hodgkin's lymphoma as well, for which she had radiation. And this is her medical therapy after her hospitalization. So what we see here on this echo is that I cannot tell what the valve, why the valve is leaking. Unfortunately, it's not playing as well here as there, but you can see that the valve has regurgitation, that the attempt for PISA is done, and it's 0.23, but you cannot see some flow reversal by color Doppler. By volumes, we try to do this with an enhanced, contrast enhanced volumes. The volumes are normal and the ejection fraction is preserved. So there is a discrepancy between how she feels to what the echo shows. How do we intervene in these patients? For aortic regurgitation, we have to have the two S's, so severe and symptomatic. She does not have severe, but she is symptomatic. And there is going to be another group of the asymptomatics that we're going to talk about. So my point is that to make the diagnosis of severe aortic regurgitation, it takes a Herculean effort here. What is your first reaction when you see a diagram like that? As confused as it could be, right? Not only have different colors, you have multiple arrows. You have multiple categories and variables that you don't know how to rank them. And guidelines are a starting point, but they don't address how many times can you measure these parameters, and what if they disagree between them within themselves? You have 2 to 3, you go this way. If you have more than 4, you go down, and you have a transition from yellow. It's a mess, to say the least. And it assumes a good quality echocardiography, which is what we attempted to do. But they don't talk about, how can we agree? And when we don't agree, it's better to not undercall it, but to call that you don't know. It is indeterminate. Indeterminate means it could be severe, but are you sure? Let's check for something else. And I think that's one of the messages here, as well as readers, as well as trainees, behooves to us to be certain. So in this case here, the patient went to a transesophageal echocardiogram. And as you can see that there is more of a central leak, there is a little bit of a more an eccentric leak. And the vena contracta width, which was one of the parameters that was measured, was in keeping with significant, with severe. And then when we do the quantification here, the ROA is in keeping with severe aortic regurgitation with some early diastolic flow reversal into the proximal ascending aorta. So we could have done this also with MRI, and MRI provides us, not only about just looking at the morphology of the valve, but also looking at the ventricle, the remodeling, the aorta, the orthopathy, and many things. And the guidelines actually say that MRI provides the confidence. Confidence is a strong word, I would say, because sometimes you can have LV dilation with some moderate AR, and the LV dilation is related to a cardiomyopathy, not necessarily to the regurgitation itself. But it's important to provide accurate and reproducible measurements of the aortic regurgitant volume and fraction. And when you look side by side, this is a recent registry here in the United States, almost 450 patients. When echo called bona fide severe aortic regurgitation, about a third of these patients were undercalled, either moderate or mild. So point is, verify this moderate AR. Always go a step beyond. Prove that it's moderate until it is not, because it could be undercalling, especially with the underreporting that we have that might be leading to this. Now, I just mentioned to you that if we're going to use MRI, we cannot also have another problem, which is using the thresholds that were derived for echo to be used with MRI. In this graph here, what I showed to you is Cleveland Clinic that 170 patients bona fide severe AR by echo. And you could have here by phase contrast MRI, the regurgitant fraction. Regurgitant fraction is how much volume comes down relative to what went up. So that's a ratio. And a regurgitant fraction that defines severe aortic regurgitation is not 50%. Yet the guidelines say that you can only call by MRI severe AR if you reach that threshold of 50%. So that's another problem with the guidelines. Not only they are outdated, but the thresholds are also wrong. Actually, in my career doing MRI for the last 15 years, I probably have seen about 10 patients with a regurgitant fraction more than 50%. By that time, the ventricle is beyond gone. It's really bad. You don't have 50% here. 4 series, almost 1,000 patients. 1,000 patients asymptomatic going by MRI, it's not small peanuts. And here you have the thresholds that associate with progression of heart failure, need for surgery, heart failure hospitalization, or death. It's not 50%, it's 33%. So if we're going to use MRI, please don't use the same thresholds, because we're going to have another penalty. So we're going to, and why is that? Let's just think about why is that the threshold is different. First is because we never had any proof that 50% is what defines severe AR. This is all based by actually aortography, by how much flow you see, which is a method that's still used in the cath lab, but not for quantification. Of course, you can see when it's horrible, but when it is into that moderate zone, you cannot quantify. The problem with that, with echo, the regurgitant fraction, what we measure as a denominator is the LV stroke volume. And typically the LV stroke volume is underrepresented by echo, whether you do this by Doppler or do by Simpsons. So if that denominator is small, your regurgitant fraction is going to be really high. Does that make sense? Here, because we measure more as LV stroke volume by MRI, we have a lower threshold. So it's lower threshold is what we need to do. Well, what if I don't have MRI? Well, you can use the CT. So the CT that was done for this patient now, in moving into the treatment, you can see that there was some calcification. The annulus is less than 90, so that's okay for the Jena valve. The periphery is fine. But also, this is AI for AI. Artificial intelligence for aortic insufficiency, right? This is that same patient that had the normal LVEF. Look at the LVEF. Is that normal? No, it's not normal. There's one motion abnormality here in the inferior septum inferior because there is a CTO of the RCA. She had mental radiation for Hodgkin's, right? So chronic total occlusion. The ventricle is not only that decreased function, but is also severely dilated. So completely different phenotype than what the echo had shown. Using that CT, and also you can see the central coaptation gap there, in which you can measure this, the anatomical regurgitant orifice area. So if you don't have access to CMR, you can use CT. And we are looking at this series now that is under review in these patients that were undercalled by echo. They were symptomatic. They were sent for CT or for MRI. This is a patient that, was said to be moderate. And moderate, but the ventricle that is horribly dilated, and you have a regurgitant orifice area of more than a square centimeter. So we are undercalling. We have problems in the diagnosis of aortic regurgitation. I think that's where we need to update the guidelines in ourselves. The second problem, which is even bigger, is the asymptomatic guys. In the symptomatic, you're going to be searching for more. But when they are asymptomatic, that's even worse, because you just say, oh, there's nothing to worry about. And the guidelines say that if they are asymptomatic, you got to look at the size of the ventricle or the ejection fraction. Well, this threshold here, which is a linear dimension, end systolic diameter index to the body surface area greater than 25. But where do these numbers come from? They come from 1983. Probably some of you were not even born by then. That's when Thriller was out. Great album, right? IBM XC was out. I mean, cassette tapes. I mean, who still practices back that way? None of us. But yet, this was the paper that Dr. Bono, when he was at the NIH, led to the observation that of 21 patients. I mean, if we publish a paper in Circulation with a little bit than 70 patients, you'll be celebrating with your fellow. I mean, that doesn't happen anymore. So 21 patients that when that end systolic diameter reached that 50 or 25, they did bad. This is still in the guidelines, but it's time to update. In fact, when we see 3 series here, this is a series from Cleveland Clinic, this is Mayo Clinic, this is Belgium. Asymptomatic patients with severe aortic regurgitation, you can see that the inflection point is not the 2.5 or 20. It's actually lower. So you cannot use the trend, you even use lower if you're going to use linear dimensions. And in fact, you see the series here from Belgium. Asymptomatic patients meeting class 1 indication. Class 1 indication is severe symptomatic. Actually, as a paradox, you do worse if you meet class 1 indication. Since when the guidelines should be written that way? Class 1 is like, please do something. Do it. Go for it. It's recommended. So it's actually better to intervene when they don't have trigger symptoms or when they are still in that category of undetermined. So we have to update that because this is where the patients are paying the penalty. We did work on this topic, and this came in the German Cardiology a couple years ago, showing again, the 25 does not discriminate, but actually volumes by MRI, which are not in the guidelines, separated. The end systolic volume index more than 45, and it's not only that, but the quantification of aortic regurgitant fraction, again, this 32, 33% that we talked about, and MRI can do that. And ultimately, when these patients finally make it to see a surgeon, they don't get operated. So there is a dramatic on the treatment of these patients. They are too good, you're not so bad, you're not so bad, now you're too sick. You missed the boat because the ventricle now is gone. And this is obviously just an observation registry from the STS. It doesn't matter the ejection fraction. When they get operated on, of course, in the red line, they do better. There might be other biases for why they did not get operated. But needless to say that the mortality is very high when they don't get intervened on. So how are we going to intervene? And that's where TAVR devices come in. Well, they have tried to use this with the Sapien or with the Evolute. It does not work. I mean, these valves were not designed for aortic regurgitation. These valves had minimal, if no calcification at all. So you need some anchoring. And they embolize, they dislodge. It's a mess. I mean, if you try to look at the success, I mean, would you take a device success here, Jason or Amit or Carlos? I mean, the 84 needing a second valve in 10% of the cases, that's a mess. I mean, that's not meant to be. You can oversize a lot if you don't have any options for, other parts of the world. They try to do that, but we need devices specific for aortic regurgitation. And this is the Align AR. The Align AR was one that, was presented at the last TCT, and line AR now was presented at 2 years at this most recent CCT, 180 patients. It took more than 3 years to find 180 patients. If I'm telling you that it's so common, how come it is that it takes 3 years? Well, it was during COVID and they refined, but the most common cause of screen failure was actually the patient was symptomatic, they did the echo and they said, oh, it's not severe, stop there. So they put the patient in the back burner. And that was a missed opportunity had they used some other advanced imaging to confirm that. So this patient ultimately got treated. As you can see, the valve has 3 markers. It's TE guided. You have to align them according to each one of the sinuses. And you deploy that, and you can see no paravalvular leak. And this patient, you see the TE there. The gradients are very low, 3 millimeters or so, because there is no calcification. So the valve can completely expand to its nominal size. And this patient ended up with a heart block, a left bundle afterwards, and because of the low ejection fraction as well, she ended up with a CRTP. This is something that we need to improve upon. Pacemaker rates are still high. We're looking at this across the trial. It decreased, but it was still in the average of 20%. And this might have to be with some of the oversizing algorithms that can be improved upon. And the second thing is that when you look at this critically too, you can see that there is obviously a KCCQ improvement after they get treated and also in the walk test, but about a third of these patients, either they had no changes in the KCCQ, they were worse than before, or they died. So are we intervening too late in these patients? That's where we need to continue to refine. In fact, when you look at the 2-year mortality curves that were just presented a couple of weeks ago at the TCT, they still continue to separate, but this is not driven by cardiovascular mortality. It's almost that you prevent the yo-yo, prevents them from dropping in the floor. Of course, there are ones that are so close to the floor, they're going to hit the floor. They're already too far gone. But majority of the mortality is not due to cardiovascular after you stabilize them, is the non-cardiovascular causes. And the LV remodeling also plateaus. The other valve that we're working with too is the J valve. This one goes up to 104 perimeter. Yana valve stops at 90, and also has these anchors that fits into the sinus and conform. The EFS was presented by Santiago Garcia and now published. 40% of these patients had a perimeter greater than 90, and there was no pacemakers for these patients. So very promising. And the future directions in this field, to wrap it up before we go to the tricuspid, is that we need to find about also that men and women, they start with different sizes of ventricles and they're going to remodel differently. To expect that women might have the same degree of dilation than men might come at another penalty, and that might be why they do worse. And the other player too might be also fibrosis of the ventricle that we can assess by MRI, whether this is scar from late GAD, from prior infarct, or from just remodeling of that ventricle. That also portends a worse prognosis for these patients. And just to conclude, this is a patient of mine, actually a professor at the University of Minnesota that came to see me a couple of years ago, and he was totally symptomatic. But he was very astute, and he's like, I heard that you can do better in imaging and everything. I said, sure, yeah, talk to me. So we did the MRI. The ventricle was called as moderate aortic regurgitation with no dilation. Same story, but asymptomatic. The ventricle is already dilated. There's holodiastolic flow reversal. By dimensions here, he's now meeting the 25, right? He's 23, but the end-systolic volume is already increased. The strain is impaired. There is some fibrosis already, and the extracellular volume of the myocardium is also elevated. So the patient is asymptomatic, but is the ventricle asymptomatic? Right. So we have to obviously establish safety and improve our profile to these high-risk symptomatic that we're not going to treat, so that we can move into the asymptomatic patients. And this recent review, we covered that in JAC. And the other part that I'm very excited that there are now 2 trials, one that is going to be starting next year. This one journey just started. We got already 10 patients enrolled. It's going fast. And now it's ran by Edwards. Edwards bought this valve it's trying to buy Yana valve. It's still being reviewed whether they can buy both, or this is going to be considered monopoly and they cannot own the 2 platforms. But both of them have CMR as the entry criteria. When the echo is inconclusive, please obtain the MRI. And there's going to be also longitudinal MRI studies to better understand remodeling and try to move the field forward. And it's very exciting. So in closing, the aortic regurgitation here, significant ER is not uncommon, but I think it's terribly underdiagnosed. And remember when the TR was the forgotten valve? Now we are just going to be the forgotten entity because the aortic stenosis, we already talked about the valve. It's just now the cousin of the aortic regurgitation is where we need to do better. And I think CMR or CT should be front and center in these patients. The TAVR devices currently do not deliver adequate results, and we need dedicated devices. And our goal is obviously to start with the high-risk inoperable patients, but the success will be the transformation of the diagnosis, selection, and the treatment of ER patients. So I think I probably should move into the tricuspid, or should we pause for questions for now?
We probably can take questions at the end.
Take questions at the end. Perfect. All right, let's go for the right side now. So for the tricuspid, this is where we have seen also another important evolution in knowledge. Of course, it was very little understood to now being front and center. And we just saw by the epidemiological data that this is actually not uncommon. It's the number one regurgitated valve disease. So we're going to find a lot of TR out there. And there are many issues related to where is the appropriate timing that I'm going to be building into that. When we look into the guideline quantification of TR severity, we can see that this is a problem that has to do with using multiple parameters and not having a hierarchy. It's the same concept. Majority of the lab are still using how much of that jet occupies the right atrium. The right atrium is the buffer, right? It's going to dilate quite a lot. Quantification should be done because quantification matters. Here we have this 5-grade scheme. It's the only valve that you have 5 grades. None of the other ones have that. And Becky and Pepe Zamorano had proposed that to use some quantification to do that, but it does not take into account the size and the function of the RV and the remodeling, which are important. So when to consider tricuspid interventions? When we have severe TR, when obviously the risk is high, the patients would not be adequate candidates for surgical risk, although at times we need to take them with the best optimization from heart failure team because we don't have devices that would be suitable for them. In whom the clinical benefit is likely, of course, there should not be enough cardiac damage or extra cardiac damage that we're going to be covering here that makes it futile, and that is suitable. And this mostly for edge-to-edge repair. The gaps are important, not having wider gaps that you cannot reach that. Obviously differentiates success from failure. Number of leaflets, the greater the number of leaflets, the more complex becomes to grasp those. And patients with leads or cardiac implantable electronic devices are possible, provided that that lead is not at the location that I need to grasp. In whom to intervene has been also an evolution of that knowledge. This has started with the TRI-score that was derived for surgical intervention, taking into account not only signs and symptoms, age, but right-sided heart failure signs, which is quite important, liver congestion too with the bilirubin and RV dysfunction, but also now validated into also transcatheter valves. And ultimately, the timing of that intervention, as we were trying to talk about, is balancing all those things in which we don't go too early because we're going to expose these patients, especially for TTVR, to a durability that is completely unknown for this procedure. I was talking to Jason before that. There's a lot of unknowns, also risk for pacemaker and many things. So how can imaging and advanced imaging here in the sense, the context of CT and MRI helps us out? It is obviously the volumetric assessment of that RV, the quality, the quantification of the TR that we can do with phase contrast, but also I would put here CT next to it, especially because CT is the one that we use already for many of the structural procedures. It can provide an exquisite evaluation of the leaflets, as I will show it to you here, as well as TR severity. This is something that we describe in our lab, the capability of measuring its anatomical regurgitant orifice area with MPR. And you can see that this quantification by CT has a great correlation with the best-in-class 3D vena contracta area of the anatomical regurgitant orifice area, as well as the remodeling of the right ventricle. And that is something that, if done properly, you can quantify. You can also describe the orifice, but look at the implications that leads might have in these patients. Sometimes these leads might need to be moved away from where you need to grasp. For example, here we are between the anterior and the septal leaflet. We need to come just down below. This is actually in a good location. And we should grasp the posterior septal as well. This case here, this lead needs to be moved because it's impinging on the septal leaflet. And about 35–40% of these patients will have already leads, and another 20% might need leads if you go for TTVR. So this is a huge group of patients that we need to better understand what are the implications of that, or jailing the lead, particularly for RCD. And leadless might not be just the answer for all of them. The anatomy as well of the IVC relative to the tricuspid valve is something that we are reporting now consistently. Ideally, it's nice to have an IVC that faces the tricuspid valve front and center. The more remodeled the heart is, the more flexure that you need to do, an anti-flexion, and a lateral move. And this is becoming a problem if you're going to clip, because it is going to create an asymmetric grasping of these leaflets. The CMR for quantification is very important, and this is a paper from the Methodist group looking at how can we quantify TR and the prognostic implication of that. They excluded patients with AFib, they excluded patients with devices, which it's good, but it does not represent the reality, right? Because these patients have a lot of AFib, but needless to say, they classify into three groups: the low, the intermediate, and the high risk. And this high risk, which is what the guidelines say about the threshold of a tricuspid regurgitant fraction, again, of 50%, which is just transposed from the mitral to the tricuspid. Let's hope for the best. And we just put 50% as a bad risk, but it's not right. So when we look into this, our own data, this is under peer review at the moment now, about 4 years into the MRI, about almost 500 patients. We excluded patients with left-sided valve disease, looking at the all-cause death and heart failure hospitalizations, and doing the same quantification methodology by MRI that was done. At the end of this 2.5 years, you have the events here. We can see that a tricuspid regurgitant fraction of not 50%, but actually 30%, whereas all the confidence interval is above 1, is what actually constituted the increased risk. So it's a lower threshold than what the guidelines suggest. And in fact, when you can see that separation that stands despite adjustment for many other covariates here, CKD, atrial fibrillation, coronary disease, EF, RVEF, PSP, is very important to understand that this threshold might be lower than what we need to understand. So that's severity of TR quantification should be lower than what the guidelines. The other part is assessing the RV function. Assessing the RV function in the context of severe TR is also problematic, and TEPSI is not the answer. TEPSI is problematic for so many ways. So perhaps RV longitudinal strain might be a meta metric, or perhaps if you're going to use TEPSI, you should use indexing to something else. In this case here, you index to PA pressure by echo, which in the context of TR is also not accurate because it underestimates the right atrial pressure so high. RV function by 3D echo might be better. If you get good images for transthoracic, please do 3D. The feasibility, about 36% of these patients, is not going to happen. And the guidelines don't tell us when we should be looking at RV dysfunction. They just say the absence of pulmonary hypertension or RV systolic dysfunction, but defined by who. So this is where 3D imaging can come handy. An RVEF of less than 45% was found to be associated with worse outcomes in a surgical series. This is by 3D echo. Same thresholds, around 45% is when they start to do badly, and also by CT. So 3 modalities, 3-dimensional. When ejection fraction is below 45%, the outcomes are worse, even when you have success going for clip. So 45% seems to be the sweet spot. The longitudinal decomposition of that function is also important. We can see that the main piston of the RV in the absence of pulmonary hypertension is going to be that longitudinal descent that TAPSI measures. And then the radial function is the other one that is going to compensate for that. But when patients lose both the longitude and the radial contractility, they're going to be in worse shape. And another parameter that we are looking into this is this forward flow, forward stroke volume. That's discounting the amount of TR. Whatever goes up forward, which is ultimately what these patients feel, seem to be associated with worse outcomes in these patients. And here's another work that is also under review. This is a smaller series of 335 patients looking at the implications of TR into the cardiovascular and extracardiovascular function. You can see that as you increase the tricuspid regurgitation, the ejection fraction might not change so much, but the forward stroke volume, or the forward RVF, goes down substantially. But more importantly, also the RV free wall strain that we measure by here by CMR. Equally important, what we saw was that there was, as you increase the tricuspid regurgitation, there is an increase in liver congestion measured by the liver extracellular volume. IVC goes up and JVD goes up. And in fact, when we looked into the secondary analysis that was just presented at the TCT, the liver ECV, which is a marker of both fibrosis and congestion, that passed the threshold where all the confidence interval was about 32. And you can see, look at those patients that have a higher liver ECV. They have all the badness there. They have more JVD, more peripheral edema. They have a greater RV and diastolic volume, worse ejection fraction, less than 45%, 46%, right? Worse forward stroke volume and everything. So interestingly, when we look into the separation of these curves, let me take you through this here. This is a tricuspid regurgitation fraction in 30%, greater than 30% in the liver ECV that is less than 32. Having bad TR is bad, but the outcomes are much worse when you have high TR in the congested liver. Not everybody. So you got to integrate not only the cardiac domain, but the extra cardiovascular implications of that. And I think that's another marker that potentially we could use for more objective assessment of the right-sided failure, potentially earlier intervention. Late GAD by MRI, and I'm wrapping it up here, also can be another important factor to consider. SCAR, whether this is MI related that involves the RV or ARVD or amyloid, sarcoid, all of these patients might have tricuspid regurgitation, but the outcomes might be dictated by not just fixing the tricuspid valve, but also the other comorbidities that they also have. And that's important to understand. MRI is also changing. It's getting modern. This is the same patient, same magnet, but different pulse sequences from a non-diagnostic image quality because of the pleural effusion. Patient cannot breath hold to a completely diagnostic study. That's what we are using. And that's what we used on the triluminate imaging sub-study that was funded by Abbott. This was CT and MRI at baseline, at 30 days, and CT at 12 months. The results were presented and now is ahead of print, hopefully coming up soon in JACC. We had to overcome many challenges and learn together. This was a labor of love. 10 sites, we enrolled more than 100 patients. The results are going to be coming with a randomized cohort, 68 patients, 10 sites. And you can see that this was on purpose, all comers. We decided to say, I don't care about atrial fibrillation. I don't care about leads. Let's just use the best in class. We're going to have to change the protocol, but we wanted to have external validity of our findings so that it was great, but you cherry pick these patients. That's not what we wanted. So this is what you can see. These patients, this is not just atrial functional TR. The RV and the right atrium are significantly remodeled. You can see patients with leads. You can see the reflux into the hepatic veins, the pulsatile liver as well, and significant tricuspid regurgitation. What did the clip do? Well, as expected, the clip reduced the TR. It did not abolish. In some patients, it reduced substantially, but it reduced substantially, which did not happen with the control. You improve the effective RVF, which is the forward stroke volume divided by the RV and diastolic volume. And here's a case example. Patient atrial fibrillation, severe biatrial enlargement, tricuspid regurgitant fraction, regurgitant volume, 98 mLs. You go for 2 clips, you reduce from 98 to 7 mLs. It's all volumetric, right? It's not pluses, 1 plus, 2 plus. It's all volumes. And you decrease by 91 mLs, the RV and diastolic volume reduce from 284 to 195. So it's very proportional. More important is not only how much you reduce, but also the forward stroke volume measured in the pulmonary artery. Because now you shunt the blood from the right atrium into the proper direction, provided that the RV is good. And that's what you see here. By CT, you can see the same phenomena. You can see hepatic vein flow reversal here and a reduction on the CT. This is from a great collaborator from Atrium Health, Marcus Scher. And when we saw this correlation here, that was a strong message that we are doing something right. This is despite atrial fibrillation, but there was a very good correlation between the amount of how much tricuspid regurgitation we reduce by the amount of RV shrinkage that we have. And you can see many more blue dots here in this TriClip group than in the control group. And this was seen not only at the 30 days, but sustained at the 12 months. in the clip, which did not happen with the GDMT. And you can see the complexity of these patients. 3 clips, micra, leadless pacemaker, mechanical valves, but we were able to do. And I think what was very important that also helped with the FDA panel approval was this correlation that we saw. So what? Is the RV getting better? But there was a correlation between KCCQ change improvement and the shrinkage of the RV. So a smaller RV will improve, obviously, the symptoms and hopefully the morbidity of this patient. So in closing, TR echo is inadequate for the RV size and function and to track changes. We could not see any reproducible metric by 2D echo in the triluminate because of the variability on 2D echo. Maybe 3D would do a better job. We could see this even with a smaller cohort by CT or an MRI. The severity thresholds associated with outcomes are, again, not 50%, and they should be lower than what the guidelines suggested, and that's something that we need to pay attention. In addition to the remodeling function, I think RV forward stroke volume and liver CV are promising new imaging biomarkers that can identify these hemodynamic consequences of TR syndrome, and I put syndrome here because it's not just the heart, it's not just the valve. And these mechanistic trials are going to inform us quite a lot into hopefully what is the sweet spot for these patients and hopefully expand the future indications. And with that, I would like to say a big thank you again for you to staying tonight with us. Look forward to the questions and again for the invitation, Eric. Thank you.
Ask the first question while people are thinking about other questions. Can you speak to the role of exercise testing in aortic regurgitation? Maybe I'm showing my age, but it used to be quite common that we would try to, when we didn't have as much access to high quality cardiac MRI, that we would look for volumetric shifts at exercise. Can you speak to where that stands now in our evaluation?
Yeah, it has fallen out of the guidelines. Unfortunately, it's now a class 2B. What we're looking with the exercise stress test, and obviously with the heart rate acceleration, we're going to shorten the diastolic filling time. And the ventricles should hopefully increase the contractility. So you're going to reduce the aortic regurgitation and you increase contractility. They have tried doing also global longitudinal strain. The problem is that with the patient breathing, even with a bicycle, becomes not good reproducibility. So the guidelines have said, you could consider, but it's not, a standard indication because we don't know the metrics that we should do. I would say that, more and more we're learning that perhaps, a TE or even less invasively echo, a CT or a CMR should be the ways that we should evaluate these patients for aortic regurgitation.
Great. One more question for me, and then maybe I'll ask others to jump in. In the triluminate experience and in your personal experience, what is the role of these approaches for patients with serotonin syndromes, or is there a role? I'm getting a lot of questions about this, guys. So you might be seeing those patients.
Well, with the serotonin syndrome and with what's it called? That I'm blanking the name here. That the valves carcinoid, right? Is that what? Yeah, I mean those carcinoids here are tough because I mean the leaflets are kilometers of this distance. It's not a good for at all, and even even prior endocarditis sometimes. Brian Weissnant from Intermountain has some experience with patients that had flared leaflets from biopsies of the RV post-heart transplant. We're trying to get a cohort of those patients. That sometimes can be tricky because I don't know what is grasping there. But for carcinoids, replacement is the best strategy. Even repair for this patient surgical is not good because the leaflets are tethered and they don't withhold. So that's where probably a replacement might be the best strategy.
I'll start with Carlos and then go to Emmanuel and then go around the room.
Joao, great talk. Very exciting field. So from my heart failure thinking, there's a volumetric assessment, which is great with this multimodality, but there's also a component of hemodynamic and functional assessment of this, mostly a TR component. Do you ever complement assessment with level 3 CPETs, looking at RV stroke reserve, PA, RV PA coupling? It's not uncommon for triluminate, or less common, but RVs that are long gone after the valve goes in, there is an acute RV failure and the patients do very poorly. So how do you address those before considering TTVR?
It's a great question, Carlos, and I wish that we had the answers at the moment. I think that cardiac exercise pulmonary testing, looking specifically of the augmentation of the cardiac output, is a key measure, because that is going to determine not only what happens to your afterload, but also what is the RV contractility that I can do with that. It's an indirect measurement of the RVPA coupling. On Triluminate, they did not obviously do that. They did baseline right heart catheterization, and we're trying to merge that data. I think, the MRI at the baseline, which I proposed to you here, was that, we can potentially try to understand what is that forward stroke volume at this exactly time. And if you come to think about that, it almost goes in almost two stages. The only way, in the presence of TR, the only way that I'm going to be able to keep that forward stroke volume, first is I'm going to dilate. I'm going to have to remodel to augment the cardiac output. Augment that with the augmentation of the contractility. That's the adaptive process. At some point, that is going to become maladaptive. The RV said, nobody listened to me. I'm too big. I'm too sick. I'm too tired. So the forward stroke volume is going to decrease. By that time, that's when the ejection fraction goes down. RVEF, RV ejection fraction measured by any of these measures. Why 45%? 45% is already bad in the presence of significant TR. That's not good at all. So I think, forward stroke volume, augmentation of cardiac output with exercise is something that we need to test. And I completely agree with you. TTVR, we had patients that had to stay in the hospital for quite some time, man. You prehab them. You might shrink some of these gaps. We had patients that came in that it was like, nothing can be done. Prehab them, diuresis the hell out of them. You did another CT. It's like, I can do clip, I can do TTVR, I can do everything here, because now there is some plasticity. But some of these RVs might not come back. You put a TTVR on that, they struggle. It is mirinone. It is, sometimes, some sildenafil. It is bad. Some of them do not thrive. So we still need to learn more.
So great talk, Zhao. That was a very nice presentation. So I have a question, one on the aortic side, another question, so two questions, one on the aortic side, one on the tricuspid side. So for the aortic side, you did mention right accurately that when echo is inaccurate, then we should do CMR. That's what the guideline recommends. Yeah. But the major problem with that right now is we don't actually have a dedicated MRI guidelines in terms of cutoff. Right, so that's why there's a lot of variability. Some centers use 50%, some other centers use 30% in order to grade severe AR. So my question to you is why still at 2024 we still don't have guideline? What's the major limitation? And it's even a bigger problem when you have to grade mild, moderate. So severe, I used 33, for instance, but when it comes to mild, moderate, what do you use in your lab, for instance? So that's on the aortic side. For the tricuspid side, I'm also of the opinion that we are actually waiting too late for intervention because the initial presentation for isolated TR is usually vague. So they typically don't have the shortness of breath or chest pain like we have for left-sided valve disease. So most times we're catching them very late when they already have RV dysfunction or liver dysfunction. Yep. So are there parameters we should be looking at in patients with asymptomatic TR that can inform those that will benefit from intervention, just like we have for asymptomatic AS, asymptomatic MR? So those are my two questions.
Oh, I need a drink after those two questions here. All right, let's start with soon. All right, we're going to start with aortic regurgitation. Thresholds, if I may simplify. What define thresholds for cardiac MRI and why do we not have? Actually, there is a white paper document that is under review now by the SCMR boards that we have written that really calls into question all these thresholds. Yes, they have been adapted from mitral regurgitation that God knows how got the 50%. And now all the valves, severe is 50% regurgitant fraction. And we have just shown here that this is bad. That should not be that way. And by MRI, the threshold that we use for severe is about 33%, okay? What defines mild to moderate? And mild, for us here, 10 to 20%. I'm again using regurgitant fraction. 10 to 20% is about mild, 20 to 30 is about moderate. Okay, by MRI, that's different than that. That's what we use for our valvular disease. 35 and above, for sure you are. And then you add the other specific signs, diastolic flow reversal, descent abdominal aorta, et cetera, et cetera. For the tricuspid side, your question was about, can we use other markers that would be coming before symptoms to trigger intervention in these patients? I think what I have proposed to you here is that we have to take not only the thresholds are again not correct, but also looking at other things as well. Augmentation of cardiac output, liver ECV, forward stroke volume. These might be new markers. Now, at what point do you scan these patients? Because you're going to be looking at the echocardiogram in these patients. For us, actually, we have a very low threshold for even these moderates. We always verify that it is moderate. Prove me that it's moderate. That is for any regurgitant valve disease. So once we confirm that this is not severe, then these patients with the moderate, they might be assessed with some biomarkers and things like that and be kept in the loop to see us every 2 to 3 years or so. If they confirm to be severe, then there's another treatment diagnostic care pathway that they follow too. We don't wait. I mean, of course, more education is going to come. You know, we started this tricuspid about 5-7 years ago. AS has been for 20 years, and we still have made small impact for the undertreatment of this disease. We need more. Tricuspid is much more front and center, but we're finding them in many ways. The other problem too, Emmanuel, is that the heterogeneity of these patients, right? They all have many histories. Left side valve disease is another 30-40%. They have mitral or aortic valve surgery. Then another 30% have leads. 78% have AFib. It's difficult to control. We love them all together. It's not right. There are going to be some subgroups of the TR. And in which one we're going to have the highest yield? Not obviously what the industry wants to hear, but you got to start at some point, because if you dilute, if you try to treat everybody, you end up not learning much of that. And you have to have significant TR to be able to remodel as well. That's the other point as well. In some of these trial-limited substudies, which is a snapshot of the main trial, 1 in 4 patients were part of it. And we took, not cherry picked, right, but they were all represented. There was a subgroup of them that we did the MRI, and the gaps are very small. It's a regurgitant fraction of 20-25 mL. Hopefully, by the time they did the echo, was a lot more TR, but TR I cannot see. If you have 25, you can only reduce your volume by 25. You cannot reduce by 50. It's not proportional, right? That's why you saw that scatter. There was a nice correlation, but you see it scatter. So we need to do a better job even calling what it is. Because not everybody might have severe. And there is this dynamism of the diuretics and the preload and everything. John, I think
You're next.
Yeah.
So question about the sort of the prevalence and our ability to treat aortic regurgitation. It's something that I find interesting because we see plenty of regurgitation of mitral and tricuspids. We don't see a ton of aortic. We see it, and when we see it, and especially when it's moderate, it often is in bicuspid valves, which none of the transcatheter valves are designed to treat. But clearly there is a good number of patients that have moderate, or at least from the data, that have tri-leaflet valves. And I guess my question there is, what is the mechanism of their AR, right? We understand why, ventricles dilate, you get TR, you get MR, you can have ruptured cords, that'll give you MR. You can have a dilated aorta, which will give you AR. But what is the mechanism of this AR non-dilated tri-leaflet valves?
Yeah, it's fascinating, John, and actually makes me reflect of what we had decided to institute with Journey as we joined the core lab. We actually go always for the mechanism if we can. If a good CT quality, we try to get to the mechanism. I will talk about that in a second here. The other piece that you mentioned about, and there is going to be a heart valve collaboratory thing starting tomorrow and next day about combined valve disease, right? I would actually have you take a look at your mitral clip patients. How many of these mitral clip patients have also concomitant aortic regurgitation, even moderate aortic regurgitation? We actually presented this as under review at the EuroPCR, 350 patients. We took patients that had mitral clip and had moderate, residual moderate. We know moderate's not good, you gotta go from it. So we took those that had moderate, go just with the mild. We took patients that had prior aortic valve surgery. And we took patients that had moderate plus TR, because we know TR is bad in this. So now I'm just looking at the effect of corrected mitral regurgitation in the presence of aortic regurgitation. And the aortic regurgitation here was moderate or greater, or less than moderate, mild or less, yeah? This moderate or greater was actually 13%, 1 in 6 patients, 7 patients. And it's actually what the outcomes of these patients is actually almost like you treated the wrong valve. The ventricle continues to dilate and they don't do well. I mean, mortality is like twice as much. So is that, and by the way, there was not like a progression of AR. Sometimes it might, because now you're going to shunt more blood forward, right, in the valve. But it's almost that you treated the wrong valve. And, you know, could you have treated the upstream valve? And if you had fixed the aortic regurgitation, because some of these mitral regurgitations, if they're not primary, got better. You see what I'm saying? So combined valve disease is going to be the new theme. And we're going to learn a lot about that. About the mechanism, I'm sorry that I did a detour here. But the mechanism, what we are seeing, yes, we had a patient the other day, a couple of days ago, annular aortic ectasia. So annulus is large, effacement of STJ. These are nice central gaps. What you have sometimes, this woman was radiation valvular disease. So the leaflets are fibrotic thickened. You've seen some of these bicuspid in trileaflet valves. Women, sometimes they're not calcified. The leaflet is just thick, right? They're fibrotic. They're stiff. They cannot coapt. You see that. The other common one is actually cusp prolapse. So cusp prolapse is almost like the secondary cusp. It is anchored into the STJ, but as it comes in, it's not the whole. By the way, those that you have the prolapse of the whole cusp, they should not be treated yet. We are learning. But sometimes you have a prolapse of just the small medial. It's like there is a shoulder. That one is a nice sweet spot. In these jets, and that's why I think in part is so underestimated. It's because the jet is eccentric in 80–90% of the time. It's a bucket of water. If I throw in front of you, it's horrible. But if I throw like that, it does not look so bad. But for him, it looks horrible. So if the aortic regurgitation is so eccentric, we're going to have problems with the quantification and on the mechanism of that.
I'm going to first introduce Ahmed Banerjee, who is a professor from University College London, who's visiting us for the next couple of weeks, and will be giving noon conference. So a plug for noon conference tomorrow.
Yes.
And then Jeff after.
Thanks very much. Just two small questions. That you mentioned the Ox valve study. While I was doing my PhD, I was doing some of the data collection for that, and that shows very nicely in the picture. You showed the overlap in the Venn diagram. So the mixed valve disease is not just now with mitral clip. Seems that our guidelines and our way of looking at things, cardiologists, we look at one at a time.
Yes.
And our guidelines maybe should have been for a long time looking at both. The other is how should we judge how frequently the frequency of follow-up for the moderate valve patient, because that still seems to be a gray area, and if you ask 5 cardiologists, you'll get 10 answers of how frequently to follow them up. How do we get to that place? Because it's an important health system, health economic question, how to use our resource. Thanks.
Well, thank you so much for the question and the comment there. At the moment, what we have been using, I was telling Bob before, and others as well, is that we have a drop down in our echo reporting system. So severe valvular disease, we say, according to the guidelines, this patient should be referred to a cardiologist. And the guy will say, oh, you're saying a patient should see me, that I order the echo? I say, sure, that's okay. It's a joke, and they laugh and everything. Thank you for saying that. That's fine. But, another 50–60% of the time, it's not going to be you. It's going to be a primary care physician. And he or she should know, of course, they might be already triggered by the fact that it's severe. But even in the presence of moderate, we have also a drop down that we say that these patients should be followed, routine echocardiogram between 1 and 2 years, and if symptoms, then refer to a cardiologist. So we adapted according to the guidelines contest that. Is that enough? It's not enough. And again, the other piece that I mentioned too is that these moderates, we always verify the moderates before we sit on them. I think that's an active part that we should take to confirm that, especially if they have some symptoms and especially if there's no good, they are symptomatic, the ventricle is not that, there's something wrong here and the images are fuzzy. Let's get something that is much more, because at least then I know what I'm watching. And I can compare volumetrically what is happening to these ventricles. We do a lot of MRI for these bicuspid patients as well, and we are doing with flows now. And it's nice because it's a much different conversation when you're dealing with somebody that is young, that has a bicuspid valve, that has severe ER. Pulling the trigger too early, it's tough, man. And these patients, because what is repair of aortic valves? Good luck. It doesn't happen here in the US. And I don't think even in London, UK, it's small number of centers. So we have, and so in these patients, I need to be much more, I put them on the treadmill. I track the CV, I check biomarkers, and I keep trying to, until they finally, and sometimes I might be able to lose one of them by remodeling, right? When there is a 75, 80 years old, you almost have like 2 groups of patients in this aortic regurgitation business. You have this 75, 80 plus women, sometimes or men, that cannot tolerate these regurgitant volumes. And the other ones, the athletic young ones, that they can give it to me. I can take it. And the ventricle keeps dilating. Those, we need to have better thresholds. The other ones, I think we are going sometimes a bit too late. Yeah.
Jeff, last question.
Yeah, just a very informative talk. Thank you. Just a quick practical question. So a lot of us have been following moderate AR in our patients for many years by echo. You've killed my confidence in that. Absolutely killed my confidence.
Just check, you might be correct.
No, you have. I'm sorry. I mean, you did it. And so, from a practical standpoint, I mean, echoes are more accessible, and from
Sure.
a health economic standpoint, is there anything on the horizon technologically with echo that will improve the data to the point where we can have that where I can get that confidence back after your call?
Well, I'll answer in 2 ways. So one is from the echo perspective that you asked me to answer, and the second one is from the MRI perspective as well. And I think they're not competitive. They're both actually good evolutions. It comes with, hopefully AI for AI. So there are 4 approved softwares now by the FDA that are working on improving imaging acquisition as well as standardization. Garbage in, garbage out. But at least maybe if you can do a better acquisition, you bring some consistency in the tracings of the left ventricle, that hopefully we have some internal consistency in that traces. We need to educate better, and we need to probably provide more training for transesophageal contrast echo, better volumes. Sometimes it's what the patient gives it to you, right? And you cannot, that it is what it is. Also, from the MRI perspective, things are improving access-wise. It's a big push. I was talking to the fellows earlier today. All the vendors are working on solutions. I know, for example, Siemens and also GE have the capability of, I have the patient, I have a magnet, I have no text, I have no idea how to do an MRI. Just put the patient there, press one button, it will do the MRI for you. That's advantage. I have a patient, but I have no magnet, I have no text. There's mobile trucks that come. We're actually using that for one of our satellites far away. It's working so far. We give them the protocol, they follow. So, all of a sudden, I think, some of these resources are starting to become available to improve. I mean, it's crazy. Like City of London, they do at a given year more MRIs, the City of London, than the whole United States of America. Cardiac MRIs. How is that possible? Yeah. I mean, it's, there is a lot that we need to learn from. Of course, it's still, if it still, becomes just a boutique thing in ivory tower, it's not gonna happen, but, you know, we need to democratize. Thank you.
Thank you, great job. Jeff, you have to ask you for DOS.